So I think we have enough people here, a quorum here, so we can get started. And I can't tell you how much I've been looking forward to doing this. To introduce Dr. Kathy C. as our grand round speaker. So you may be thinking to yourselves, why is Sam introducing a pediatric otolaryngologist? Well, you know, Kathy, as she knows, has meant a lot to me over my career in terms of just being an inspiration. But she is also a very technically gifted surgeon, and I think a closet facial plastic surgeon, because she does a lot of reconstructive work in microtia, as you'll see tomorrow, and a lot of work in the palate, and is very much a scientist at heart too. I remember when I interviewed at UW way back when in 1994, 20 years ago now. Kathy was one of my favorite interviews, along with Craig, of course, back there. Sorry, Craig, I don't mean to diss you there. And there are a lot of us here from UW, and I know Joanne's going to be going there next year. Look, I told her I'm very envious. She's going to spend a year with Kathy. Kathy is the Richard and Francine Loeb Endowed Chair in Childhood Communication Research at the University of Washington and Seattle Children's. Kathy is an alumnus of the University of Michigan in the integrated undergraduate and medical program, which is a very prestigious and difficult program to attend. And then she did her residency at UW and then her fellowship in Boston, at Boston Children's, and then went back to the University of Washington. So she's going to be talking to us about standardized endoscopic assessment of velopharyngeal function. Tomorrow in our course, she'll be talking to us about microtia and congenital ear surgery. And I'm very proud to introduce Kathy to you tonight. So, Kathy.
Thank you so much. It's a privilege to be here, and I appreciate the invitation. I'm not smart or clever enough to have any financial disclosures, but I do have a few other disclosures. I am a University of Michigan alumnus, as Sam says, and these pictures, this is Sam operating in Cambodia in his Wolverine surgical cap, and it goes to show that you can take the man out of Michigan, but can't take Michigan out of the man. And this is his, his poor children, his, I don't know where to, his daughter here in the Michigan, Cammie, that's Cammie as a Michigan football player. Oh, thank you. But I've also spent some quality time with Sam, and Sam's kind of a facial plastics guy, right? So he's always in those super nice suits with the little shine and the nice ties, but he's relaxing here in Hawaii and in the Madras, Bermudas, and with Cammie again. I'm sorry I don't have any pictures of Elise and Beth, but and look, he looks so relaxed with the lay on. I have some other disclosures. I feel like there's a real relationship between the UW and Stanford. I think we've trained many of your faculty, Kay Chang, Alan Chang, Davood, and we had the privilege of training Nushin, his wife, as a facial plastics person. And you may wonder why this is here. This was our going away party for Charlie Cummings many years ago when he left UW to go to that other place in the East Coast. And this is Lisa Orloff. And I didn't realize that Janice was on your faculty too. So we really kind of have this long relationship, and I think so. We've trained a lot of your faculty, and we're going to repay you also on the other end coming back because we've trained a lot of your residents, and I think we've trained more Stanford residents than any other residents. You may or may not recognize some of these folks, but Patricia Yoon, Eunice Chen, Dylan. And T most recently, and we're very much looking forward to Joanne coming to join us. So getting on with that, just to kind of set the stage, we're going to shift gears, and I'm glad that there's a different audience now than there was this afternoon, because this is so not facial plastics, but it does have to do with reconstruction, and VPI is the only reason to fix a cleft palate, right? That's the main reason we repair cleft palates. So it is important, and the objectives that I put on the little sheet were that I want to share some information about understanding clinical diagnosis of velopharyngeal dysfunction, think about critically comparing the different types of instrumental assessment for velopharyngeal function, and then kind of through some of the studies that we did, try to understand the sources of variability so that we can come to consensus and have a unified understanding. And I think even though you may not see kids with VPI, some of these principles will generalize to training and how we train people, how we're trained, and so it just happens to be about VPI. So we'll review VPI, talk about treatment options briefly, and a lot of times surgeons like to hear about surgical outcomes. It's really not going to be much about surgical options, but assessment of velopharyngeal function and implications of instrumental assessment, kind of why is this important. As Ernie Weimuller, one of my former chairs, used to say at a lot of talks, so what? And that's always a big question, so what? So velopharyngeal insufficiency, is incomplete closure of the velopharynx, but it is kind of the quintessential surgical endeavor because, whoops, sorry. Let's see if we can get this to happen. Oh, it's playing. Sorry. So, I don't know if we have audio. Well, that's all right. So I was going to play kind of pre and post-op audio segments for you just to show that kids can be totally unintelligible, and then you can do a surgical procedure and they sound totally normal. It's immensely rewarding and makes a huge difference to these kids. And so we hang our hats on this clinical assessment that is based on perceptual speech assessment. We do a history and physical examination, and then the instrumental assessment is really designed to try to quantify how much velopharyngeal function exists so that we can intervene appropriately. And just to give you kind of, to start at the top, when kids come in with unintelligible speech, when we see kids in VPI clinic, it's super easy because they've been to the speech pathologist and they tell us the kid's got VPI. But what's more common for you guys is a kid comes in and you can't understand anything they say. So I like people to have a template of what is speech. And speech is comprised of voice with breath control and moving air past the larynx and the vocal folds, generating a sound. Then articulation, moving the tongues and the lips to make the sounds. So putting your lips together to say pa 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 ba 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 ma ma ma. Sequencing those sounds to make words and fluent speech, and then velopharyngeal closure. And so the velopharynx has to close on production of all sounds in the English language except M, N, and NG. And so when kids come in and they're saying a-e for puppy, you know that you can see they're not putting their lips together. That's an articulation problem. It's not VPI. So it's just helpful to have that template so that when you see kids who are having intelligibility issues, you can start to piece it out, because VPI is the one component of speech that is a surgical, is really primarily a surgical problem. Everything else needs speech therapy, so it's important to sort it out. And then I'm going to go through this just really to explain how speech-language pathologists think of VPI. And it's kind of seemingly, it's really a little bit confusing because there's velopharyngeal inadequacy, cleft and non-cleft, and then they use velopharyngeal insufficiency, incompetence, and mislearning. And the speech-language pathologists will separate these things out. And so I just want to briefly go over it with you. I actually don't make the distinction between inadequacy, insufficiency, and incompetence, but some people do, and it's reasonable to understand what they're talking about. So cleft VPI, let's see, is really related to unrepaired cleft palate, submucous cleft palate, something called occult submucous cleft palate. We're not going to talk about that. And post-surgical insufficiency. So that insufficiency really is that there's too large of a velopharynx and insufficient tissue to generate closure. So non-cleft VPI is post-adenoidectomy VPI, post-tonsillectomy VPI, disproportion in the craniofacial kids, or ablative status post, resections. Velopharyngeal incompetence is something else, and this is this dysarthria, so coordination problems that affect the palate in addition to the articulators and other parts of the vocal tract, and then apraxia. And so those kids are going to need speech therapy in addition potentially to managing their velopharyngeal dysfunction. And then finally, this velopharyngeal mislearning, which is it's an interesting entity in that there are speech habits that are learned by the kids that make them sound like they have VPI, but they actually don't have true VPI. And so these are the kids that you need to know about, because you do not want to operate on these kids. You can get them completely obstructed and they'll still sound the same afterwards. And so that's kind of my cue to emphasize the importance of working with a speech-language pathologist for careful speech differential diagnosis. So the clinical challenge when we see these kids is to restore normal resonance during speech production, but to maintain a patent upper airway, because you can get them totally blocked off and they'll sound hyponasal and have obstructive sleep apnea, which is a whole other set of problems. So with that in mind, the surgical options that we have for these kids can be broken down into palatal procedures, and we like the furlopalatoplasty, which is a double opposing Z-plasty to reorient the abnormal sagittally oriented levators into the transverse position, so it's a Z on the oral side and the opposing Z on the nasal side. Pharyngeal procedures, and we like the sphincter pharyngoplasty, the superiorly based myomucosal flaps that get transposed across inferior to the caudal to the adenoids, and you create what one parent so aptly said, a speed bump in the posterior nasopharynx. Palatopharyngeal procedures are classically the superiorly based posterior pharyngeal flap, and then posterior wall augmentation is something that some people are really kind of rejuvenating. So when I started at Seattle Children's as a faculty member, there was a plastics fellow who was very interested in anatomy and function of the palate, and we sat down, and it was one of these things where, you know, people did whatever they wanted to do. When kids had VPI, all the surgeons were doing different things, and you ask them why they're doing it, and they couldn't give you a reason. And you read the literature, and everyone reports 95+% success, but they didn't have what the selection criteria were. And so we sat down and said, let's think about this, and let's base it on the anatomy, what we know. And so if the patients have the sagittal levators, then they should go to furlopalatoplasty. And because the furlopalatoplasty is this brilliant, beautiful procedure that realigns the muscles of the palate by incorporating the Z-plasty. You get lengthening of the palate, so it makes intuitive sense that you would want to optimize the palatal function. If they have transverse levators, then we're going to use sphincter pharyngoplasty. And this was because the speech-language pathologists were keeping a list of kids who were having problems, and we were seeing a lot of obstruction with pharyngeal flap. And so they said, you know, we got to stop doing this pharyngeal flap. And Joe Gress came to Children's from Toronto and said, let's do sphincter pharyngoplasty. It's a better procedure and less obstruction. And we didn't really know that at the time, but we were willing to just have, everyone came to an agreement. We all agreed that this is how we were going to triage patients. And so we have this modification of the sphincter. But the sphincter is really nice because you have so many degrees of freedom with this, in that you can control the width of the flaps, the length of the flaps, degree of overlap, and so you can really tailor the procedure to a defect. But then that begs the question of what's a defect. But I will say, and that's kind of a disclosure, is that we're very biased. So our experience is we do furlough and sphincter, but the question has arose over many years, how does a sphincter compare with the pharyngeal flap? And so I'm just going to throw up these. There have been 2 randomized multi-center studies to look at that question. The first one out of Mexico City, Let's see, there's a red thing. Yep. So at any rate, sphincter versus pharyngeal flap. Sphincter versus pharyngeal flap. 25 in each. They did a power calculation, and this is kind of interesting. So they get a power calculation, 23 per group, to get a 20% difference. A pretty defined group of kids, unilateral cleft lip and palate, non-syndromic, 4 to 8 years old, endoscopy and fluoro post-op, assess the speech, sleep assessed by history, and they didn't say how many different surgeons there were, but they had good speech outcomes and 0 OSA. I don't know that you ever believe anything was 0, but at any rate, that's what they reported. So no difference in outcomes. And then the European group did another trial a few years later. Interestingly, they did a sample size calculation with the same parameters and got a requirement of 133 per group. So I'm not sure exactly the details of that, but so their study is twice as many patients, but underpowered by their calculation. And maybe, and I don't know if because they have a more diverse group. They have unilateral cleft lip and palate, bilateral cleft lip and palate, as well as isolated, a bigger age spread. They looked at speech 3 and 12 months later and sleep 1 and 12 months later. And interestingly, they had their speech result a year out was the same, but it wasn't as good at the 3-month mark. So it's the same. They did see more obstruction in the kids who had pharyngeal flap, but it turned out not to be statistically significant. So the bottom line is, I don't think sphincter is better than pharyngeal flap necessarily, but we have more experience with it. I think people get good at what they do, and so pharyngeal flap. I've been accused of saying pharyngeal flap sucks, but I don't think that. So our approach to instrumental assessment then is that in the yellow boxes is what the speech language pathologists do. So they do the perceptual speech assessment. They do a differential diagnosis. If kids have compensatory misarticulations, they go straight to speech therapy to unlearn their bad habits. And then when there are no compensatory misarticulations or the compensatory misarticulations resolve, then they get diagnosed with VPI, and then they come to ODO. And we do a history and physical examination, always screening for obstructive sleep symptoms, knowing that that's the trade-off. If you decrease the air coming out your nose, when you talk, it's going to be the same problem when they breathe. So if they have obstructive sleep symptoms, we want to treat their obstructive sleep symptoms. If there's no resolution, we would offer them palatal speech prostheses. So this is a palatal lift, and that's a speech bulb. They're two different things. You should know what they are. And most people haven't seen one, and that's why I put the picture up there. If they have no obstructive sleep symptoms or resolution of their obstructive sleep symptoms, they all go to nasoendoscopy, because that's the exam where we can assess the levator status. And if the levator's transverse or intact, they go to video fluoro. And if they're sagittal, then we assess the gap size. If the gap size is large, we get a video fluoro on those kids. And we'll talk about this in a bit. But nasoendoscopy is where you can really assess the status of the palate, of the levator muscles. And so this is the same thing up top, the assessment bit, and then it has ramifications on the treatments, because if they have sagittal levators, they go to furlopalatoplasty. If they have transverse levators, they go to sphincter. And based on, when we looked at 150 kids, how they did, kids with large gaps were more likely to have persistent VPI. So we'll do this combined furlow sphincter.
The purple looks a little better.
Okay, thanks. Thank you. So as far as instrumental assessment, then the most common clinical assessments are nasoendoscopy, and I put this picture up because it's really important to stick the scope in the middle meatus so that you're getting a bird's eye view. If you run down the floor of the nose, as we do for usual nasoendoscopy, you're getting this tangential view, and you can't really see what you need to see. And that's what we're looking for, the notch on the nasal surface of the palate. That's the adenoid pad, the lateral walls, and the nasal surface of the palate. And so when they have this notch, that's an indication that the levators are going in the sagittal direction and not in the transverse direction. And then multi-view fluoro, and a lot of people haven't seen this, and if you read the literature, the speech literature, the VPI literature, they hold fluoro out as a gold standard. But the reason is really a historical reason, that fluoro came before the endoscope. And so let's see if we can get that to play. Well, so at any rate, on the AP view, so we put barium, yeah, go ahead. We put barium drops in the nose, and on the AP view, you watch the lateral walls move toward the midline, and on the lateral view, you watch the palate, the nasal surface of the palate close, approximate. So those are the views on the multi-view fluoro, and so we're looking, in theory, looking at the same area, and so we started having questions of how do these tests differ, and what do they tell us? That's okay. So thank you. So what we decided to do is we were doing these studies, and before we had an organized approach to this, we decided to use a reporting scale that had been reported by this international working group in 1990, using that the scale rates the palate movement, lateral wall movement, and some subjective characteristics of the velopharynx. And the nice thing about the scale is that you can use the scale applied to either fluoro or endoscopy. We start at rest with the solid lines and measure or describe how much it's moving relative to rest. And so it's a relative rating scale. On the endoscopy, we do this, we draw a line, approximating the resting velopharynx, and then you basically break it down into a 10-point scale from right to left and then from palate to posterior. And so so this rating would be like a 0.2 on the left lateral wall and a 0.1 on the right lateral wall, and the palate movement, the posterior pharyngeal wall movement would be 0.2, and the palate movement would be 0.2, but there's a central defect, that V-shaped defect. And so we would, draw, in the old days, we'd draw it out on a piece of paper and we'd have that. And so when we were implementing that system, we started with our documentation, and we had the initial assessment with all the speech parameters and started this database, basically. And we were collecting this information and collecting all the endoscopic ratings and the fluoro ratings also. So we then started, in a short period of time, developed a pretty robust database. And so we wanted to answer the question, how does endoscopy compare with fluoro? So we had 140 patients who had their perceptual speech assessment, endoscopy, video fluoro, and they were all rated using the Golden Kushner scale. This was one otolaryngologist rater, one speech language pathologist, and so we compared. We wanted a single number. We generated this gap area index that I'll talk about, and wanted to know how the area compared with VPI severity, because there's a lot of comments in the literature that gap size does not predict VPI severity. So we're interested in that. This is just a diagram of the resting velopharynx in the bold outline, and then how well it moves. And so this rating of the right lateral wall movement toward the midline and the left lateral wall, and then the palate moving toward the posterior pharyngeal wall and posterior pharyngeal wall movement. And so the gap area index, we took a rectangular model because it's more intuitive for people, and it looks more like a rectangle. So we did the sum of the lateral walls and the average of the palate closure to generate that single number. And so when we did this, Derek Lamb, who is now a pediatric otolaryngologist at OHSU, did this study and did a nice analysis. So we did the scatter plot of the gap area index on fluoro versus nasoendoscopy. And you see it looks kind of like there's a relationship, but there's a lot of overlap of these dots and a lot in these in this near zero range. And so this is why it's important to work with a statistician. So the statistician said, well, in order to unclump those and see what's really going on, we can do a natural log transformation. It's hard to get your head around that, hard for me to get my head around that, but they said it's totally legit. And what it did is it separated out these guys, which is kind of interesting. So what happens is on fluoro, there are a lot of kids who look like they close, but on endoscopy, they actually have a gap. And so that's kind of an interesting finding, and definitely kind of affects how we use these tests and why. So, and the correlation coefficient was 0.34, which is, not okay, not great. And but when you boot these guys out, it shakes out, and it's much more highly correlated with a R of 0.77. So all these measurements are subjective. It's all a relative rating scale, and there's no gold standard, so there's no way to actually measure it. We worked on that initially, actually, because of the distortion of the endoscopes. It's hard to standardize those, so we don't have an objective measure, and there is uncertain variability between raters. So around this time, and sorry, one more slide. So we concluded from this study, and I didn't go through all the details, but nasoendoscopy and fluoro are related. The gap sizes are similar. So we are measuring the same thing and getting similar measurements. But the nasoendoscopic assessment of velar movement has a stronger association of VPI, and nasoendoscopy is more sensitive to detect these small velopharyngeal gaps. And that's this issue of the zeros on the fluoro, that you can see the gap on endoscopy. And that's just because you get compression of the view on on the fluoro, because you compress everything into 2 dimensions. And then it turned out in this study, we also saw that the velum has the biggest contribution to velopharyngeal closure. And that's important because I think you have to be careful when you do pharyngeal flaps, because pharyngeal flaps create 2 lateral ports that require good lateral wall motion, and that turns out to be not very common. So we learned that on endoscopy, the strengths are that you get the bird's eye view, so you can see these small gaps, direct visualization, and you can get this assessment of the palatal status because you can't see that notch on fluoro. The weaknesses are that you're unable to assess the cephalocaudal level of attempted closure. And the fluoro, as far as the fluoro is better for kids with really complicated speech. You can see timing issues, weird attempts at closure. There are some kids who actually use tongue backing. So if you look at the lateral fluoro, the tongue is lifting up, and that's passively elevating the palate, and the palate doesn't actually move. So you can do stuff to the palate, it's not going to move. And that's a behavior issue. So you get the compression of the views, which is why you get the closure on fluoro when you see a gap on endoscopy. And if there's asymmetric palatal movement, you're not able to lateralize that. So we were interested then. So around this time, we had done this study, and we felt like we were understanding more of what these different tests told us. And another otolaryngologist joined us, John Perkins joined us, and he was interested in VPI. And so we wanted to know what our variability was, what our inter and intra-rater reliability was. So Patricia Yoon actually did this study where 6 of us rated 50 segments twice and looked at what our variability was. And so we looked at, we had 2 faculty, 2 fellows, and 2 speech language pathologists looked at inter and intra-rater reliability. And the fellows were pretty good. The attendings were better. Speech language pathologists were not as consistent. And then we looked at intra-rater reliability to see how people did on rating a second time. And actually people did pretty well. The fellows did pretty well on palate movement, 0.8 and 0.6, on lateral wall motion, 0.9 and 0.75, very similar to the faculty. So internally, people have their own little clock of how they're using this rating scale. And so we concluded that the intra-rater reliability is acceptable. Providers with more experience were more consistent and similar in their use, but the subjective ratings were used less consistently. And so around this time, or a little bit before we did this study, Harlan Muntz had a meeting with some people in Salt Lake City to plan research projects around VPI. And we all wanted to do these multi-center studies, but we didn't have consistent rating. We didn't know how to triage these kids and how to bin them out, how to describe them. So then we wanted to do a multi-center study. So we did a multi-center study looking at inter-rater and intra-rater reliability on endoscopic exams, and we got 8 different centers, 16. Each center had to have 2 people doing it. Everyone rated 50 segments twice, and we looked at what it was like across the country. People who we knew going into it that people didn't typically use the scale, but they weren't using anything. We talked to them, and they said, oh yeah, well, we don't really, we just say whatever we see. And so in part this was kind of a way to get the word out that there's a scale out there, but mostly we wanted to see what was the variability so that we could lay the groundwork for doing these multi-center studies. And our hypothesis at the beginning was that the inter-rater reliability was not going to be very good. And our hypothesis actually, and I can prove it because the IRB was written, that we do this study and then we develop a training tool. And so this was just kind of the background work for that. The inter-rater reliability and intra-rater reliability for things like gap size percent was 0.63 for inter-rater, 0.86 for intra-rater. So the intra-raters are all pretty high, above, well, 0.79, but about 0.8 or above. But the inter-rater is not very good, not as good, 0.4 to 0.6. And then the statistics as a measure for the subjective thing. So we noticed this on the single institution study, that the things that we rate: notch on the nasal side, Passavant's ridge, aberrant pulsation, gap size categorization. They're all over the place. So again, these are the things, people do better with numbers, I think. So the possible interpretations, one of the authors came up to me and said, well, the rating scale sucks. We should just throw out the rating scale. And I said, well, then what? What will we use? How will we describe this? And so our little thing was, well, maybe training might help. So then how do you train people? So we decided to generate consensus. So this is the coming to consensus. And we didn't know if it was really possible or not, because it's hard to get people to agree how to do tonsillectomy. So how would we expect to get any agreement? But we embarked on this little project to generate this scale. And using the Golden Kushner, the same scale we talked about, with these subjective things which we knew were problematic in the studies that we had done, both at our own institution and in the multi-center study. And we had this background, so we had these background studies. And early on, Linda D'Antonio had done a study talking about inter-rater reliability on endoscopic assessment, but the design that she proposed was that they had a VPI clinic and they had everyone sitting in the same room rating at the same time. But our studies were all individual otolaryngologists rating on their own because we thought that was more realistic, that people would be sitting, in the clinic rating. So we wanted to develop this tool. We're going to use a Golden Kushner scale to give it a chance, apply to nasoendoscopy, and come to some consensus. So we used the ASPO VPI study group, and we just called it the year it was in Seattle, and we said, okay, we're going to have this meeting, and we're going to do this. And so people showed up early, and we sat in the auditorium, and I brought 24 segments of endoscopies, and we selected 9 that ranged from closure to large gap. And we all rated them. I wasn't thinking, I don't know why I didn't do this, but we should have rated them twice and then rated them afterwards. But we rated them beforehand and then rated them afterwards. So we rated them all individually, and then we sat in a room and decided and assigned a rating that we all agreed on and called that the consensus rating. And then the following year, we floated it to the ASPO group. We had an open invitation to ASPO. Anyone who's interested in coming, checking it out, and commenting on this can come. And it was in Las Vegas, and I thought for sure 3 people were going to show up. 63 people showed up in this room, and they agreed on the ratings, on our consensus rating. So we thought that was pretty cool. So we had this consensus rating. And just to show you some of the subjective things that are so problematic, A and C are the same person, B and D are the same person. So this is a Passavant's at rest. So this is at rest, the velopharynx. And then on phonation, and you can see this contraction of the superior part of the superior constrictors. Passavant's ridge is a muscular contraction. It's not an anatomic thing. So people say, oh, we put in the sphincter at the level of Passavant's, but you can't see that because you cannot see a Passavant's while a child's under anesthesia. It's a muscular contraction. It's an active thing. And it's not necessarily related to velopharyngeal closure, because some kids will have a Passavant's lower than the level of attempted velar closure. Totally different story. But that's a Passavant's. And then the notch on the nasal surface of the palate. At rest, they're transverse across there, and on closure, they have this notch. And so that indicates that particular person has a submucous cleft palate. So then I'm just going to spend the last few minutes to show you what the video instruction tool looks like. Oh, yeah. Well, we need the video at least, maybe not the audio.
We use the rating system, the Golden Kushner scale,
So
proposed by a
David, too, narrates
multidisciplinary
this
international
and
working
gives a-
group.
I'm just going to play a couple
This
of seconds.
scale is
Don't
a
worry, it's not
standardized
too long.
method to describe the degree and pattern of velopharyngeal closure.
And this was posted on the ASPO website and got taken off when the ASPO website got revamped. And so, but I think I might post it on YouTube because it's 9 segments. And so what we do, is we play a segment of the representative endoscopy segment, and then we play it again with the ratings put up on it. And so there are 9 different segments, and I'm going to just show you the small segments and then whoops. So
Give cake to cake. Sissy sees the sky. Sissy sees the sky. Give cake to cake. Sissy sees the sky. Sissy sees the sky.
And all of that. And we have a long version and a short version. So this is a small asymmetric gap. The adenoid lateral wall, so he gets closure 1.0 on this side and probably 0.9 on this side. But that's the kind of kid who would look like they get closed on fluoro, right? Because you'd see this closure and you wouldn't see it. So endoscopy, I think, has become probably the most reliable instrumental assessment. And then at the other, so those were segments 1 and 2, and then I'll show you the last two. So I think the cool thing about this is for the residents and the fellows, you can spend the whole year and see one here and one there, but this is a way you can sit down and in 5 minutes see the whole range from closure to large gap. So here's a super large gap with a notch, limited lateral wall motion, so 0.2, 0.2, 0.2, no passivants, no pulsations, etc. So, so that's what the video instruction tool looks like. And so we want to use this to see whether we can improve consistency of rating. So the next step is a multi-center study after insisting that people look at the training tool twice, or however many times they want to, and then re-rating, and we're gearing up to do that. The universal scale would help us interpret clinical studies, so if people use this, then we would be able to understand whether the studies are generalizable to the patients we're considering. And I think improved characterization of the function should allow us to improve outcomes. So my conclusions are that there's variability in application of the rating scale. By doing these studies, we get a better idea of where that variability lies. We have a better understanding that raters are pretty good at rating. They have an internal consistency. The intra-rater reliability has been pretty good consistently. The greatest variability is in these subjective ratings, and shockingly, we were able to reach some consensus. So I'll just say that this work is related to the work of a lot of people, and the speech-language pathologists are critical in all of this. Doing this work has actually helped us in our relationships with our plastic surgery colleagues, and so they've been very cooperative. The VPI study group is something really fun to participate in if any of you guys are ever available, and the statisticians are super helpful. So thank you. This is a picture from Scott Manning of Mount Rainier. Kind of cool.
Thank you very much, Dr. C, for that. I want to open the floor to any questions anyone may have. I have a couple of comments. Any questions?
Yeah. Thanks.
Do you ever see any of those patients who have a pharyngeal flap done, and in the future they do develop for adults with this smaller constricted maxilla without
Yeah.
enough?
Yeah.
And then they do have CPAP, severe sometimes, if they do have the pharyngeal flap, and for others they can't do CPAP. Do you ever reverse a pharyngeal flap?
Yeah, it's super easy. You just snip it and then put a couple stitches on the mucosa, and they usually do. Their sleep apnea usually improves, and their speech usually remains stable.
Really?
So we don't have any heartburn about cutting.
Let's say in adults, when you reverse pharyngeal flap, you never saw perhaps a severe VPI or anything along the lines of
Nope. Well, if they're, we've seen kids with pharyngeal flap who have persistent VPI and obstruction. We've seen kids with pharyngeal flaps who have no VPI and obstruction. Basically, their speech stays about the same as it was pre-op, and their obstruction usually improves. If they have maxillary hypoplasia with the class 3, sometimes their sleep doesn't get as good as you would like. And in fairness, the maxillary constraint is not necessarily a result of the pharyngeal flap, but may be a result of the clefting, because the cleft, yeah. Yes. Sure.
Any thoughts on the use of temporary injectables in patients with OSA?
You know, we haven't done that. Sheila Kofer is doing a lot with, she's doing her trilogic thesis, or has done her trilogic thesis using deflux, which is permanent as an injectable. I'll have to say that I am a little bit scarred about injection into the posterior pharyngeal wall, because one of the first cases I did with Mark Richardson when I was a resident was trying to dig out Teflon out of the posterior pharyngeal wall that had migrated. But you're talking about temporary, and I think that'd be a reasonable thing to do. But most people are looking for, particularly if they go to the OR, are looking for a more kind of durable result.
Peter?
Peter.
You're about 10 years ahead in terms of trying to classify BPI as we're currently trying to do the same with sleep endoscopy.
Right, yeah.
As you know, Sanjay institutions have a nice effort along with Dylan.
Yes.
What advice do you have for us? I mean, we're at the beginning of this process, and how do we get to consensus? We're all over the place on it.
I think it's challenging, but I think numerical rating scores are, have a role, and then just bringing the group together and talking about it. And I think it's an issue fundamentally in medicine, right? We don't have good metrics for a lot of what we do, and I thought I was just getting crazy about BPI, but then during this process, Bill and Melinda Gates, they started the metrics, the Institute on Metrics, because they're interested in health outcomes at a global level, and they recognize we don't have metrics to do a lot of this stuff. So I would just say stick with it. Don't let the naysayers get you down, and come up with something and have people use it and see. But I don't think it's an appropriate response to say, we don't need to do that, because we do. It's helpful.
I think that, that's really kind of the comment I was going to make. So for the folks in the audience who maybe aren't going to be doing this type of work, the fundamental lesson to learn here is that you can't really measure outcomes if you don't have a validated scale for the anatomy and for the fundamental anatomic problem. And that's something that in facial plastic surgery we're certainly trying to do with nasal obstruction, and I've tried to come up with something similar. And it's really nice to see how you've gone through the steps the right way, and I think it's instructive for all of us, and I really appreciate that. Are there any other questions at all?
I just have to ask, did you choose that picture because there's a mound in the background and this room in the foreground?
No, but that's great. That's brilliant, Rob. Thank you.
You're just making us jealous of all the snow in the mountains up there.
You go. I know,
We don't
water.
have that down
water,
here.
water everywhere. Sorry.
That was 6 years ago when you could actually see it on the
Yeah.
Right. Well, thank you very much.
Thank you.
Thank you.